got a few things to talk about tonight. Dan has some updates about concussion. Sarah and Dane have some things around readiness and around some nutritional strategies for low energy availability, and Adam has some ideas around ACL injuries. So the idea today is just to have a bit of a chat. We're not going to redo all of the talks, but we are going to try and highlight some of the key things that we think were, I guess, some of the key take-homes from our session in Queenstown. So firstly, thanks guys for joining. Appreciate you giving up your time this evening. I'm hoping that you'll all have something to add for all topics, but Dan, you're at the top left of my screen. I'm not sure where you are with everybody else, but your topic for the day was around concussion and the assessment of concussion, particularly in the early phases, and some of the tools available. So are you able to talk to us about some of the new tools that might be available for clinicians to use out there?
Yeah, sure. Cheers, Mark. Look, I think everybody's pretty familiar with the sport concussion assessment tool because it gets used around the world, and that's a really strong tool. It's got heaps of value. It's got some bits in it that are really helpful, but some bits that are not quite as helpful when you're trying to do what you're trying to do in a concussion consult, which is make sure that you don't miss the things that are a lot worse than concussion, and then try to work out for those who are concussed what sort of prognosis they might have, who's going to get better relatively quickly, who might not. So there's certainly some utility in that tool around the symptom score, but what's quite cool in New Zealand is we've got this New Zealand specific tool called the BIST, so the BIST. It's actually, we're up to version 2, so it's called the BIST 2. And that's a neat little tool which you can find online. It's been produced by ACC in collaboration with some of us, but also some other experts. And it's really a great way to work through a concussion consultation. It's got some good stuff at the start. So it's got some information about red flags or things you need to really worry about when someone comes in potentially with a concussion. And then it's got a little symptom checklist, not too dissimilar to what you might be familiar with if you've used the SCAT, which gets you to go through some things either with the patient, or the patient can do it independently, and they score a range of symptoms out of a given number. And then depending on what that number comes to, it gives you a sense of whether they're going to get better pretty quickly. So 90% of people get better in 4 weeks from a concussion, or whether they're going to have a more prolonged recovery. And it's all really encapsulated in a pretty easy to use tool, and it's designed for our New Zealand environment. So it's a good thing to have in your toolkit.
That's right, and it's not sport specific, is it? It's more for the general population.
Yeah, that's right. I mean, it just recognises the fact that people get concussed doing a whole variety of things that are not specifically related to their sporting pursuits.
And I think one of the things about the BIST that potentially is quite useful is that it helps clinicians categorise the dominant symptom or the dominant cluster. Can you talk a little bit about the way that I guess that the expert consensus groups are talking about with different treatment algorithms?
Yeah, I think it's really part of this move that we've seen over the last few concussion and sport groups. This is the group that produces the sport concussion assessment tool, the SCAT. Excuse me. We've really seen this move from a rest and wait and ride it out to a short period of rest, maybe 48, 72 hours, where you really try and wind things back mentally and physically to then move into a really active treatment phase. And what the clusters allow you to do is it allows you to sort of block together different groups of symptoms that people might have when they're concussed, and then you can layer on some intervention tools. So when people come in saying they're feeling a bit dizzy, or maybe they're having some difficulty reading or tracking, you might see that they score highly in a vestibular cluster. And then that's really useful because then you can target that with vestibular physiotherapy. People might come with a different set of symptoms. Maybe they've got neck pain, maybe they've got some difficulty with driving, and that might point to a cervicogenic cluster. And then again, you can target your intervention. So it just helps inform what you're trying to do now, which is reasonably quickly after the concussion, you're actually trying to get people to do something, and you're also trying to get them in front of the right people to do rehabilitation in the same way that we'd rehabilitate any other injury now.
Yeah. So I mean, I think for the GP audience, potentially it's a really good way of trying to decide what to do next with the patient. So high symptom score, potentially concussion service, high vestibular score, potentially physiotherapy assessment. And I guess for the physiotherapy audience, it is also a good way of trying to decide what to do next. This is a patient I should hold on to versus this is the patient I should refer on. Is that kind of how you're seeing it?
Yeah, I just think the good thing about it is that it answers the two key questions I think you need to answer when someone turns up and you're worried about their head, because that's what the situation is, right? Someone turns up, you're worried about their head. The first thing you want to be able to do is make sure that it's not something significantly worse, like an intracranial pathology, and the BIST has a nice series of red flags. So you can tick that box with asking the red flag questions and doing a targeted exam. And then you've got this great symptom scoring, which, as you say, Mark, just really helps your disposal. What are you going to do? Maybe they'll get better. Maybe they need a bit of physiotherapy. Maybe actually they've got such a high symptom burden score that they need a interdisciplinary concussion service.
Sure.
So, yeah, good tool.
So Dane, one of the things that I think is increasingly clear over time, the more time I see patients with brain injury, the more I realize that one clinician type can't treat that problem often well in isolation. Do you think there's any role for sort of dietitians and nutritional strategies with concussion?
Yeah, I think one of the challenges, especially dealing with a lot of athletes with concussion, is the deconditioning compared to any other injury. So there's often a lot of, no exercise. There's a lot of potential for sort of muscle atrophy from just not doing anything. So I think it's really important to try to maintain a consistent diet. Also, the importance of sleep and just trying to maintain a normal routine. Appetite is something that can be impaired. So I think potentially consultation with a dietitian can be really helpful during that time to really put some good habits in place and just doing everything possible that might assist in recovery. And generally just a good healthy diet is the key, but it's not always possible during that concussion.
Yeah.
Mark,
So
Adam's,
yeah, go for it, Adam.
I was going to say I've seen a number of young females with concussions that have carried on for a while, and one of the symptoms that tends to drag on the most is fatigue. And I think it's a bit remiss if we're not doing a further blood test to make sure that there's not an iron deficiency that's going along with that, particularly if there's missed periods, stress, because there might be an underlying iron deficiency that's contributing to the fatigue. And I've found that when you treat that starts to get better, and some of the symptoms sometimes pick up. So I think use it as an opportunity to just make sure that we're not missing anything from a medical or a nutritional point of view that can, as you say, Dane, then we can start working on that to help optimize their fuel.
Yeah, and it can be a sort of double-edged sword. That fatigue then affects appetite, and the kind of circle gets bigger and bigger.
Yeah, I think that probably just aligns with that whole when things are not going well, having a team approach almost always works well, whether it's a concussion or a knee injury or something else. So Dane and Sarah, I know that you kind of had a little bit of a tag team. You were talking a lot about some of the current trends and things around RED-S. Obviously, there's a very popular topic at the moment, and we are looking to do a specific webinar for that later in May. So for those of you who are interested in that, we do have a lot more information. But Dane, perhaps from you first, I know there's a whole lot of stuff around the new consensus statements regarding RED-S. And around the terminology around lower energy availability. If you got anything you want to add about that or share?
Yeah, probably one of the key things that came from the update last October is I guess, like you talked about, the terminology of low energy availability. And if you look at the new health and performance model, you'll see the arrows. So the arrows, when you look in a bit detail, are sort of, there's a gradient of light red to red, and that sort of emphasizes the concept of what we call now problematic low energy availability. And it's just to give a bit of context that there will be periods of time that athletes or individuals are exposed to low energy availability. It doesn't mean that they have REDs or there's a high risk of REDs. It might be waking up in the morning, you haven't eaten. There might be a situation that you have a really well-resourced team where you might try to have a weight loss intervention, or you might have an obese patient that will benefit from weight loss and being in a state of low energy availability. So the concept of problematic low energy availability is when that exposure is long enough and there's potentially other added factors around stress. There can be the culture of the environment, especially if it's around body composition. And that's where we really need, I guess, the clinical workup to understand if there has been a sort of those key body systems have been affected. And I guess the recommendations really emphasize the importance of a diagnosis by a expert in the field, like not just I guess a medical expert, but someone with experience in RED-S.
Okay, and Sarah, what do you have any other ideas about some of the key updates from those new consensus statements? So Dane's obviously touched on that one.
Yeah, I think this it's all been quite exciting, as Dane and I get a bit excited about and was quite passionate when we were talking about it in Queenstown last week, because some of the guidelines are actually, like, you can see how far we've come in the kind of 6 and 7 years that this has been something we've been seeing. I talked last week and just keen to highlight the RED-SCAT2, which is a really useful clinical assessment tool, and that's something that's really been amplified in this consensus statement. I've had some emails since we did the talk last week, and it made me reflect that the stage 1 of that is screening. And screening can be any of the community kind of assessment tools that we have, like the LEAF-Q or the LEM-Q, which is the male one, which is, I believe, just been validated. And so that's a really great tool that physiotherapists and GPs can use to try and identify whether someone might have an issue with energy availability. And I think that's quite good, because I think that's the role of the GPs and physios in this particular area, because even in this IOC RED-SCAT, it is basically outlined that this diagnosis should actually be made by a sports physician as a diagnosis of exclusion, and they've been quite firm on this. So that's quite a change from the previous IOC consensus, and I think that's because it really encompasses the need to ensure that there's nothing else going on. So that was one of the I think really key assessment tools that came out very clearly put out in this new consensus.
So Sarah, I think most of the people listening will be very used to thinking about, or probably aware at some level of RED-S among female athletes. So you mentioned obviously in male athletes. So what are the things that might prompt you to think about low energy availability in a male athletic cohort?
Yeah, I mean, we're starting to see a bit more of it, because I think that the challenge has always been that it's quite hard to pick up in males. So in females, often one of the signs is loss of period. And so that's quite a thing that people can easily screen for and refer onwards. But for men, it's often a little bit more insidious, and often fatigue or low mood is one of the first things. And actually specifically loss of sex drive or loss of early morning erection is often seen in the setting of male low energy availability. So there's just a few specific questions that can help people think about whether an athlete might be suffering from this. And I guess the other part, which Dane and I would see a fair bit, is thinking about what sport they do. So sports like even weightlifting or boxing or things, or martial arts, where they have to do a cutting component, or there might be an obsession with a power to weight ratio, such as often seen in road cycling. So I think always linking it back into the sport, but then using those specific questions relating to gender is helpful.
Yeah. And for those male athletes that you think might be at risk there, is the treatment similar? Is the approach similar? Increasing energy availability, reducing energy expenditure?
Yeah, so the approach, the number one bit is the diagnosis. And so I think that's always going to involve a set of blood tests and questions and a physical examination, as well as maybe looking at training logs. So I think that's actually part of the treatment, is actually doing the diagnosis, because I think it informs the education piece. But the key bit is working out, if there's a little bit of an overlap with overtraining syndrome as well, and then looking at the, nutritional logs, which Dane and I will connect on as well, and then working out if there's a psychological component that needs to be addressed, because it's sometimes hard to work out if there's a low mood, depression, the chicken and the egg, if that came first before this. So I think the treatment's the same in terms of needing to fuel better and optimize energy availability by eating, basically, and it's easier to get on top of your nutrition if you're not training quite as hard. So often as part of the consult, there is some form of reducing maybe the intensity or the duration of exercise as part of recovery, but it does, and it needs an individualized approach for sure.
Yeah, and Dane, just kind of expanding on that, I guess we're kind of, again, probably most people would be aware of trying to increase energy availability, but the different types of energy, the importance of carbohydrate, that seems to be something that the statement's looking at as well. Is that right?
Yeah. So I guess there's a bit of an evolution of, rather than just focusing on energy, looking at the different macronutrients and their impact. And one of the key ones that sort of emerged in the last few years is carbohydrate availability. And there was a nice sort of review published in BJSM, I think, middle of last year, which sort of for the first time put a bit of a, I guess, a mechanism together which potentially leads to carbohydrate availability amplifying the negative impacts of low energy availability. So, and that kind of then comes back to the timing of how we eat and the potential negative impacts of training in a fasted state, especially if we get the exposure too much or we get the balance wrong.
And Dane, we would see a little bit, just to add in something there, like with the gym culture that it is and the social media setting that it is of the high protein diet and high intensity exercise and a lot of gym based lifting where people go high protein, but they really, so their output is high, but they're really underdoing their carbohydrate intake. That's something that I think we both would see, and this consensus supports that.
Yeah, and Louise Burke looked into this last year in their supernova studies in race walkers, where they actually compared low energy availability to low carbohydrate availability in bone metabolism, and it was actually the low carbohydrate availability that was the key driver in that sort of down regulation. So yeah, the timing and how we eat, and avoiding those long periods without eating, and looking at the culture of sports and how we go about trainings is a key part of that.
I mean, it would be fair to say there's a lot of stuff coming, isn't there? Like, I think you've talked to us before about how you can consume the same number of total calories, but have a different diet composition and have a completely different outcome from a weight loss perspective, energy availability perspective. Am I right in saying that? Yeah,
absolutely. I think the challenge is probably 90% of the nutrition information is focused on creating weight loss or an energy deficit for the majority of our population, which tends to be more towards the overweight or obese. But that athletic population, what we're learning is that polarized diets of macronutrients or prolonged periods of fasting have potential implications for the bone and the muscle. And so it's just, putting that all together is challenging, and the messaging around social media makes it pretty hard for athletes to follow now.
Yeah, I mean, one of the fascinating things for me is that my take home from spending more time with you is that what we think we know about good, quote unquote, good diets is probably not right.
And I guess the biggest thing that will come in the next 10 years is, as we learn more about the gut microbiome and the bacteria, which we're just scratching the surface of understanding, it comes back to diversity and balance. And then when you take a food group out, that normally has some pretty negative implications long term, but there might be short term, gains, but I think we'll start to see more and more of that research evolve. Yeah.
So Sarah, like I said, we are going to come back and focus more in depth in this, but do you sort of have any sort of high level insights about how, particularly in a primary care setting, we might go about managing these kind of RED-S or energy deficit patients?
Yeah, I think the key, I mean, it's a tricky one, and it's something that's really hard to do in a short period of time, because it's actually quite a sensitive subject for some people to bring up. But I always say when we're talking about this topic, that the key thing is trying to work out, with even just a few questions, if there's a purposeful underfueling drive or if it's completely accidental. And so I think if we can separate and work out whether someone's got some disordered eating habits, and maybe I'm asking even down to the end of the spectrum of a clinical eating disorder, versus someone that's just so busy running around doing heaps and actually doesn't have any poor relationship with food, then I think that completely decides what we need to do next. Often those who are accidentally underfueling, which I think you can pick up easily with a few questions, they're often just a really good person to send on for a dietitian review, some food education, and even, if they're not disordered, tracking their food for a few days and their output, just to see how, what the mismatch is. Whereas the opposite is completely, like I would never get someone to track their food if they're severely disordered, or go down that track. It's a bit more of a psychological problem that needs to be addressed. But I think that's one of the key things of where you target your education. And then a basic set of blood tests, often for the GPs, if someone isn't getting their period, looking at their hormonal profile and the red scat, and the has a whole range of how to stratify what kind of severity someone might be, and then what to do with them in terms of onward referral. So I think those are the key things I would try and work out in an initial consult, and then work out if they actually need a further workup and assessment.
Yeah,
those inadvertent underfuelers are I always think of the ones I sent to you, Dane, and I think, you know, that school kid who's bouncing from morning training, running through the house, picking up a banana, jumping on a bus, trying to get to school. And then I think the real light bulb moment for them is, you know, when I've sent quite a few of these patients to you, and you show them their day, and you show them actually what they are putting out in terms of energy, and then they show you what they're putting in, and it becomes a real light bulb moment for a lot of them. And they're often people, you know, they're often high achievers as well, so they've got pretty good potential to have good habits, right? They just need that guidance, and the way that you illustrate it with the little graphs, I love your little icons, lines up really nicely.
So I think that's probably quite a good point. Like, do you have or any of you have some good ways of trying to determine energy input versus energy output? Like, is there a nice way that you have to kind of measure that or illustrate that for your patients?
So I can briefly talk. There's a couple sort of angles to your question. One of the, I guess, from an assessment tool, and what the new consensus really tries to emphasize is that doing an assessment yourself is not a way to diagnose low energy availability. So there'll be a significant amount of error if I ask you how much calories do you eat, how much do you expend. That might be for 24 hours. It's not a clear picture. The other side of that is how we try to help athletes or patients recover, is then trying to use their current training to give them understanding of what their requirements are to build up to that, rather than using it as a diagnostic tool. We've just done research, so we're just about to publish research on recovery from RED from a nutrition perspective, and some of the key insights we've found was probably, as you would expect, I think there was a 90% of our subjects underestimated their energy expenditure significantly, and also underestimated how much energy they needed. And what we also found was, like you guys talked about, that light bulb moment of the biggest cause of anxiety was increasing energy. But once they had that understanding of what that looked like, it was the easiest thing they implemented. So if you just go away and say, just eat this because you need to, it's not really going to connect. So trying to make it scientific and to show them that structure, which takes a bit of time, but I think it's important to outline to them.
So how about, so I know Sarah, so Sarah and Dane, obviously this is your jam, and you're very good at doing it. Dan and Adam, you know, perhaps you're not quite as expert as these other two. Have you got any sort of ideas about how you identify these patients and what you do to help engage with them?
Yeah, I mean, for me, I'm trying to capture people often in a consultation where LEA is not the primary reason they're in my room. And I think, as we've alluded to tonight, it's a hugely complex process. And as Sarah alluded to, actually, when she's taking the history and the amount of time she gives this consult, that's part of the education process, is watching the patient realize all these symptoms that they've not really understood actually have a unifying diagnosis. So especially in my people, I think, are inadvertent underfuelers, I usually talk to them about just one part of their day, which is their morning training session, and then what they refuel with afterwards. Because what resonates with me too is what Dane talked to us a while back, which is that you can't also catch up, you know. So if you do all your exercise in the morning and then expect to refuel all in the evening, then that also doesn't necessarily work. So, you know, you have these conversations with kids who are going out and doing an hour and a half of exercise in the morning, and as I said, you ask them what they eat, and they grab a banana on their way out the door, or an up and go, and that's meant to fuel them until they come through to lunch. And when you look at them and ask them that question, they really realize, hold on, this is a clear mismatch in terms of what I'm doing. And that's usually my conversation starter to get them in front of the likes of Dane, because I think it's really easy to do this topic poorly, because of the sensitivities that Sarah's alluded to, but also because if you're not doing it all the time, you don't have exactly the right ways to bring people on what is ultimately, it's a bit of a journey, isn't it, guys? Like, in terms of, it's not like a lot of other stuff you see where you come in and it's all, all just happens in the 20-30 minutes you've got with someone. So that's my little conversation starter. I usually ask them about a key training session and how they refuel. And normally in our busy high school kids, for example, even they can realize on reflection that there's a huge mismatch.
Yeah, and I guess one of the things that one of the things that resonated with me is that, Dan, you started off talking about the SCAT. Sarah, you then started talking about the SCAT. Obviously, that kind of reflects the research groups and the involvement of the IOC with both of these things. But it would be fair to say that both of these problems, concussion and readiness, are not problems that do well in isolation with one clinician, one guru, their best shared and best saved. And so I think one of the things that we've become very aware of over the past few years is that these consultations often are quite well conducted online. And so just for those of you out there, if you're looking for more access to expertise in this area, Sarah and Dane are both available through these online type forums. So
we actually, just to interrupt you, Mark, I sometimes find the online sometimes a little bit more, I guess, patients are in the comfort of their own home, they have supportive family. That's often can be a bit more of a relaxing environment for them in these sort of challenging consultations.
And I think that's one of the key things we talked about last week, and I just have to say it because it's one of the things I think is one of the biggest changes is the movement away from, like when I say I'm going to send someone to Dane, for example, dietitian, for some people who've got a disordered past history, that brings up the PTSD of body composition testing, which we have dramatically moved away from in most of sport, and that's part of the cultural change that's required around the raising awareness of REDS. So one of the things that I'm always trying to dispel is he's not going to sit there and do, unless someone who has excellent nutrition knowledge, might be an elite person with no disordered habits and who's really keen on body composition testing. For most people, we don't actually do that because we're focusing on the fueling and the positive aspects of restoring energy availability. So it's one of those things that we have to set up well to get buy-in from the other individual, as an example.
And also, I think this online forum, was there's 5 of us all sitting in our houses. It's a really nice way to, and with people with busy lives, with multiple people who are invested in that problem, to be able to join at the same time. Just specific, not just specific to this problem, but having the doctor, the physiotherapist, the coach, the athlete, everybody all in the same place. It's a really
or the boarding school athlete with the mum from home. I forget that one. Yeah,
that's a good one.
Mark, the only other thing around what I sort of ask, I would be asking about morning energy levels. We do that a lot as a screen. I know at elite teams that's one of the questions we ask in the morning. How are you feeling? And the reason I ask that is because if it's quite low, say if they're chronically sitting at a 4 or a 5, you're asking them, so why do you think that is? And it might be they're not getting enough sleep. It might be that, a skier came in the other week who's, when she has to do skiing in the winter, she's still going to bed at 10:30 on her phone next to her bed, but she's getting up at 3 in the morning. And her periods drop off, energy drops off, everything drops off. So what's changed? The sleep. So I think, yes, we talk about the energy, but the other thing is that we know more and more now that you need a good 8 hours sleep a night, particularly if you're a teenager, to be able to recover properly, because the sleep is it's the biggest free hit that you have to recover and regenerate and to perform really well. And I think that's now the third pillar of what we talk about. It's not just the exercise and the nutrition, but it's the sleep. That's the other thing that we really need to sort of ask about now. How much sleep are they getting at night? And is it regular? And try and get them back into that sort of, I want to bounce out of bed every morning. They're not going to bounce out every morning, but you want them as a pattern to be sitting, 7s, 8s as much as they can.
Yeah, and I think the quality of that sleep, Adam, that's one of the key things I always ask is, like, We know that impaired sleep or frequent waking can be a symptom of LEA. So
Agreed, yeah.
So it's a key thing to really inquire about.
So Adam, you have been lurking down in the bottom right-hand corner of my screen. So I'm pleased you've reminded me that you're here. So your talk the other day was around.
I'm sitting at 8 and 9, which is good.
Well, as you can probably tell from my throat, it's probably just as well that I'm isolated at home with my slightly dodgy respiratory symptoms. But your talk was around ACL injuries, and so one of the things I'm quite keen to kind of dig into you with is around the treatment of ACL injuries. And so I know you talked a bit about indications for ACL reconstructions, as well as, I guess, some of the kind of newer ideas around the non-operative treatment of ACL injuries. So do you think you could kind of give us a bit of a rundown about where you got to with that?
Yeah, it's a fascinating field, because up until a couple of years ago, an ACL was ruptured or it wasn't. So it was very binary in what happened. And a lot of it was very much around, well, if you've done your ACL, you see a surgeon and you may well get surgery. And now there's some nice evidence over the last 10 years that sort of suggests that, first of all, non-operative rehabilitation can be just as effective for most people than having ACL reconstructive surgery. But that's all dependent on what they want to get back to as far as the sport. So it's the demand of the patient or the athlete sitting in front of you. And these are nice studies that came out of Scandinavia, where they could either offer someone non-operative or operative treatment. The interesting things about those studies were that even if you went down the non-operative path, there was still about a 40-50% crossover for people who had ongoing instability in their knees, who subsequently required an ACL reconstruction. So if you've got instability in your knee and you've done your ACL, you need to get an ACL reconstruction. I think we all agree on that. It's what happens if someone's sitting in front of you and they've said, oh, look, I think I've done my ACL. So we called about you hear a pop, pain and swells in ACL until proven otherwise. And I think now we're sort of looking at, well, let's get the MRI scan. And the other thing that we're now finding is that there were some studies that looked at that group that were doing the non-operative management, and they did MRIs of them down the track, and they found that up to 50% of those showed evidence of healing of their ACL. Now, we've got to be really careful about what healing of the ACL is, because healing of the ACL could be on an MRI scan. It looks like it's all joined up again. Now, has it joined up tight or has it joined up loose? And I guess there's a new grading system that we look at, and that sort of talks about that. But then an ACL is healed if you're not just what it looks like, but how it feels when you examine it. And I guess when you look at patient-reported outcome measures like a KOOS, and so to say, well, how's your function going? So if you're coping really well, you're not having any instability, your knee feels good, there's no swelling, there's no pain, and everything's hunky-dory, then that's a good outcome from an ACL rupture. But I've had a look at ACLs over the time. Some of them will heal, some of them don't heal, but they still feel exactly the same, as in they're coping quite well with them. So I think the other thing that's come out from particularly studies from Melbourne, where I'm from, with Julian Feller and his group, looked at what's the chance of getting back to the sport that you were playing after having an ACL reconstruction, and the figures aren't that great. In the community, it's about 60% will get back to their previous level of competitive sport. If you're an elite athlete, it's about 80% that you'll get back to your sport. And the other good evidence came out of that was that the re-rupture rate, when you look at having an ACL reconstruction in competitive sports, about 5%. So that's in elite athletes. So they're getting a physiotherapy, basically physiotherapist living with them the whole time to allow them to get back to their sport. And they're generally getting back to sport at about no earlier than 9 months to really high impact pivoting sports. But they're getting back about 9 months, maybe 12 months. That's sort of the norm now. But then there was data looking at overall, those getting back to sport after an ACL reconstruction at about sort of even 9 months afterwards, if they were younger, the results were horrible. There was almost a 30% chance of a re-rupture at 4 years, or a re-injury to an ACL at 4 years. And so this is where a lot of, are we doing our operative management as well as we can? And I guess some of the data has now come out and said we probably need to delay those who are under 20 a bit later. They can get back to their sport, maybe 18 months. And I know Sarah was talking about snow sports athletes. If they have an ACL reconstruction, we push it out to about 18 months now. because it's not just whether they've had the ACL reconstruction, they've had the surgery and the grafts in and it looks good. It's how they are physically, mentally, and they've done all their rehab. So you're only as good as the rehab that you've done for your ACL. So there's a lot in this around. And then the good thing is that when you look at that data, which said that it's a 30% re-rupture rate at 4 years, you look at the New Zealand registry data. Now, New Zealand's one of the only countries, certainly Australia doesn't, but New Zealand does, it has a registry looking at the outcomes post-ACL surgery. And for the community and who have an ACL reconstruction, the re-rupture rate here is 5%, which is really good because that's at the elite level that we would see in those elite studies. So the re-rupture rate is actually pretty good here. It's very low. But again, just looking at that a bit more, they looked at graft choices, and we're talking about now, traditionally we used to do hamstring grafts over patella tendon grafts, and it's found the patella tendon grafts do way better in terms of they've got a lower re-rupture rate, but also they get back to sport quicker than the hamstring grafts. So there's a lot of rich data that's coming out of New Zealand, particularly through the registry, which is sort of guiding us and saying, well, your risk of having getting back to sport is better if you're young, you're a high demand elite, high demand, high pivoting sport. So netball, rugby, soccer, basketball, skiing, probably you're young, good to go away and probably look at having an ACL reconstruction. But what we also know is if you do a non-operative rehab first, you'll improve your outcome down the track. So there's two parts to it. Yeah. There's a lot in that.
That's quite an interesting point. So, as you know, I work in proper football, the one with the round ball, and played mostly in Europe. So, one of the interesting things that I've learned about the Scandinavian countries is that while they have excellent healthcare and really good access to surgery, people, when they tear their ACL, generally don't have access to surgery for several months. So there's a requirement to do good quality rehabilitation and to have objective outcomes before they actually become eligible for surgery. So I'm not really certain where I'm going with this conversation, but it's an observation to say that in Scandinavia, you talk to patients, they view non-operative treatment of ACL injuries as a genuine option. Whereas my perception, seeing these patients in New Zealand, you start talking to them about non-operative management and they look at you like you're an absolute lunatic. Like, this ligament is busted, I clearly need surgery.
Yes.
I think my question is, do you think giving everybody access to good quality rehabilitation before surgery would reduce the number of ACL reconstructions and improve outcomes? So there's probably two questions there.
So yes and yes. The actual data that from the New Zealand registry shows that if you delay the ACL reconstruction out to 12 months, over 6 months, you reduce the re-rupture. The earlier you have your ACL reconstruction, you almost double your chance of having a recurrence. So delaying it out to 12 months is better. Now, that's not great for professional athletes who've got to get back. They've got to get back to sport, and they've got to get back to get their money, and perform. But I think we've just got to go slower on how we rehabilitate these, because you want to be operating on a knee that's really, really, really got good function, full range of movement, no swelling. They've got good quads. They understand the rehab that they've got to do. And then when they come out, they can just jump back straight into that, and they can do really well with their rehabilitation. So I think, we're moving towards more of a longer delay to having ACL reconstructive surgery, unless there's a really strong indication for that. Now,
I was just going to say, Adam, it's interesting that I agree. I think we've gone for the prehab and the getting function back as best we can, so that instability is the only thing that they need to restore with the surgery if they go that pathway. But actually, it's quite interesting that we're still adopting, which I think is a good thing, early diagnosis. Because I think humans need to know what they've done. They had their knee separate and the knee swelled and it doesn't feel good and they often can't work. So I think that whole early diagnosis, so we've got information to then have those decisions, is probably quite a great path to be sitting in, so we can have these conversations. And I think that's probably something that, I don't know, do you, being an Australian, do you think we do well in New Zealand or differently?
I mean, look, I think you do well. I must say that the appetite for injuries in the media in Australia is unbelievable. So people are doing ACLs, it's all over the front page of the paper, it's everywhere, it's a big deal, probably is in New Zealand here. So, but we probably have many more sports that you see. There's more exposure, so it's more there. So we see where it fails, I guess. Not that it fails, it's just that some people just it's going to happen. I mean, I guess that's the thing. The other point you make, Sarah, is around, you know, we get the diagnosis early, and it's really important, I think, that we present the facts to our patients around what's the consequence of your ACL injury. Now, your knee's not going to be the same. You have increased your risk of getting post-traumatic arthritis in your knee by 6 to 7 times, regardless of whether you go a surgical pathway or a non-surgical pathway. So this whole thing, I've got to get my knee fixed because then it's going to be better. That's not exactly right. Now, the New Zealand data is actually quite good because that sort of is a bit better than the international data because it's about a 3 times increased risk of arthritis at 10 years. So it shows that what we're doing in New Zealand is actually really, really good at restoring stability and restoring function into knees, but that's because we probably use a stronger and a better graft, which is the patella tendon graft. So we've got to wait and see what happens to the data coming from the rest of the world about, are they following what the better grafts are, and is that sort of stacking up? But again, you know, all your data comes back to what's the demand of the sport that you're testing. You can't compare netball to football to Aussie rules football. They're different sports. So I think we try and jump them all together. And I think that that's where sometimes your lower demand impact sports, you can probably get away without having an ACL. Or so, yeah, I just think what we're doing in New Zealand is actually very, very good because we're led by really, really good data.
Yeah. So Adam, you mentioned that at a high level, we're not doing a great job at informing our patients about the risks of arthritis. What about how do you think we're doing around talking about injury prevention strategies or the ability to reduce the risk of the next ACL injury?
And that is really important. And I think we know that the injury prevention studies that we have, not just from skiing, but even just in all sort of sports, can reduce ACL injuries by 50%, whether that's the FIFA studies, whether it's the netball studies, the rugby studies, the ACC sort of injury prevention stuff. But there are studies in skiing and snow workers, which shows that if you put in a twice a week injury prevention program, where we've got to try to get rid of the mismatch or the asymmetry between stability between one leg and the other, because there's a higher rate of injury on the left leg. So that's the non-preferred leg that tends to get in trouble. So if we can get that balance right with a good program, 3 months into a ski season, but then after an ACL, you have to still do, after an ACL injury, you still have to do that strengthening program twice a week for the rest of your life while you're going to be doing those high demand sports. If you do that, you'll reduce your risk of a subsequent ACL injury. So, you know, just because you've had the surgery doesn't mean that you're fixed. You're not.
Yeah.
It's a lifelong commitment to keeping that strong.
So, I mean, I suspect you're speaking to the converted with this audience, but I think it is good to remind ourselves that this is not an injury that we're fixing with surgery, and that there is a need to continue working beyond surgery, kind of lifelong, to not have this injury. Dane, I'm interested in your feedback. So we've shared a few patients recently with this type of injury. So I'm thinking of a few patients that are high performance professional athletes that have this injury and often will have a 12-month rehab period. But also the ones that potentially might have been a high performance athlete, then they're now 40, they put on a bit of weight, then there's increasingly symptomatic for them. Do you think there's a role for nutritional strategies, or well, clearly there's a role for some nutritional strategies there, but how would you approach those two types of clients? So the guys, I guess,
you got two sort of types of clients coming from different scales, I guess, when you go back to sort of the energy availability as well. I think with the older patient recovering from injury, or, you know, trying to get on with life, obviously maintaining a healthy body weight is key. I think the important thing last year being at the summit when David Hunter spoke was just re-emphasizing that weight loss is important, but weight loss without exercise doesn't have the same results on pain. So there's an importance there to maintain muscle function, and that, I think, there's a lot of the role of nutrition and putting a good diet together rather than just having a real focus on rapid weight loss, where we probably got a good chance of losing a lot of muscle mass with that weight, and that might be, you know, detrimental to I guess the overall quality of living. The other side is that as a professional athlete is, I guess, the period of time where they might be, lose the stimulus so there might be the loss of protein. What we're thinking about there is maintaining energy balance and working with the athlete, especially when there might be a period of immobilization, and just trying to maintain muscle function, but from the other side of things.
Cool.
I actually frequently see the energy availability, the reads really amplify actually post a significant injury for those who are slightly disordered, because there is a huge fear of weight gain because of their inability to exercise. So often getting onto that early, and the education around fueling well is really important.
And it is a time where we often see athletes, when they do have these long-term injuries, where they start to experiment. They try life-changing interventions. We know that negative energy balance has significant reductions in protein synthesis. So we don't want to, especially a healthy athlete, to be in a negative energy balance in those first few months of recovery. That will have significant impacts on the healing and the function.
I think the other thing that resonates with me around just listening to we've sort of compared and contrasted the ACL consult with the RED-S consult, and we've talked about how that RED-S or LEA consult is long, and there's a lot to kind of work through. And I think one of the key things we need to remember about the ACL consult is that there's quite a few choices here. You've got non-operative management, and within that you've got non-operative. Maybe you might think about bracing, and that's it's an option, not a panacea. So I think that's important. And you've got your surgical options, but I think you've actually got time to help people work through this process, because there's quite a lot to take in. And I think people get to a point where they give a classic story, they come in, they get their knee examined, they get scanned, but actually bringing that patient back a couple of times to help walk them through that process, you've got that time. And I think it's important to utilize that, because as long as you're doing your prehab, you're not wasting time. I think that's a really important point. People are pretty keen to get on with things, but take the time to walk them through those options.
And Dan, I think the other thing that we're doing a lot in clinical practice, and you can see with concussion with the BIST, and the BIST is how you're feeling at this point in time. The same with knees. I will give someone a KOOS patient-reported outcome measure at the start and say, well, we're going to monitor your knee function for the next 12 months, because I want to get an idea of how this feels. And people come in at 3 months, and you're not just asking, have you had instability in your knee? You sort of say, well, how's this impacting your life? And the KOOS really captures that nicely. And you can track that over the next sort of 9 months. And people come back and see me at 9 months, and they go, you know what? My knee's really doing well, and I don't have any instability. And then they're sort of going, so do you reckon I can get back skiing? And I'm like, okay, let's have a look at this. And I guess one of the things that I've sort of found, sometimes you'll go back and you'll re-MR a knee because you just want to see. You go back and look at the report, and you go, we used to just report them as complete ruptures or intact. And I think we've got to move away from that, because now the imaging is so good, we can see if there's a partial tear, if there's a stretch. And what I've sort of found is some of those, there might be some fibers that were holding on. And that's when you start to see that there's a little bit of healing, and their knee is actually starting to get better. And that's really reassuring for the patient to go, you know what, I've done all this rehab, and my knee's actually as good as it's going to get, and it's feeling really good. So there's a lot more confidence that you can get from that. So that's why the KOOS, I think, is really important, because you add that together with how does the knee feel and the instability, report of instability, because that's really lending you towards the surgical sort of pathway. And as I say, that's multidisciplinary care. Yeah, so we're involving the others and the other experts who should be involved in this. And I guess that's where a lot of this goes. It's not just us managing it. We're sharing it with physios, with GPs, dietitians, psychologists, particularly some of the ACLs, when people are trying to get back to what they want to get back to, because a successful return is getting back to your pre-injury level of activity, not just getting back to sport. I'm really, it's easy for someone to sit on the bench and say, oh, I got back to my sport, but was I back at what I was at? No, I wasn't. We want to get the outcome to get you back to being as good as you were before your injury. And that's the same with the concussion. That's the same with everything that we do.
Yeah, I think that's a really good point. Probably for all of the conditions we've talked about, is empowering your patient to make their own decision rather than railroading them towards surgery or something similar. So as you said earlier, surgery may well be the best option for a large cohort of your patients, but making sure they understand the pros and cons, making sure they understand how to get the best result from their surgery. I think that is probably, I think, in my experience, the biggest opportunity to enhance people's care, right? So I'm conscious that we
Your
said that
voice
we're
is
going to
going?
start. Yeah, my voice is going, and we said that we're going to not go on too long.
Yeah.
So just maybe if I could summarize, Dan, I think one of the things that you talked about was utilizing the BIST as a decision-making tool.
Yeah.
And certainly if you are referring patients to us, we're starting to use the BIST as a triaging tool, as someone who's doing really well, who needs a bit of advice, education, and a return to activity, maybe work, or is there someone who's likely to come into an interdisciplinary service that might need a neuropsych, might need an OT? So I think it's a really useful tool, and we'll pop the link to the BIST and the emergency department version of the BIST into the chat with us. Dane and Sarah, I'm really looking forward to exploring this with you in May. So for those of you who are interested in energy deficit, nutritional strategies, looking at hormonal balance, these sorts of things, come join us in May, and we will elaborate that more. And then Adam, obviously, some interesting insights about knee injuries, and a reminder that these are things that we like seeing within this interdisciplinary approach as well, and are well set up to see them quickly and promptly through our acute knee service. So I'm going to start up with Sarah. Sarah, thanks very much. Dan, Dane, and Adam, if you have any questions from this, please feel free to post them. I think this will go out on our Facebook page, but if you post them there, we'll do our best to answer those. Otherwise, hopefully this was, at least 50% as good as the in-person session in Queenstown, maybe 65%, I'm not sure. But we are interested in dabbling with these webinars in this format again, so keep an eye out for some more. Thanks very much, guys, and all of you out there, we look forward to catching up with you in due course. See you later.
Thank you.
Thanks, mate.
Cheers.